Dr. Gulec and myself will be reading questions, and then we'll have the panelists to answer them. I suggest we have questions submitted through chat and Q&A. Perhaps, Seza, let's start with chat, and then we'll go to the Q&A section. So first question goes to Dr. Jim Fagin. How do we get from RNA-seq raw expression data to TDS, to thyroid differentiation score, question mark? How was the sweet 16 genes chosen? Also, are there any ERK inhibitors? I guess there is more than one question. Jim, would you like to answer them?
Yes. For some reason, I can't put my video on. It says here that the host has disabled that. So, first, in terms of getting from TDS to from RNA-seq to TDS, to my knowledge, right now there is no commercially available platform, and maybe Yuri, you could comment on that. That is actually looking at providing this type of information. It's certainly doable on patient samples to give the relative expression of the various thyroid markers. It would have to be sort of normalized to some controls and then provide a TDS score. The TDS score was essentially derived from the departure from the mean for each of these genes, the mean of 500 tumors that were analyzed by TCGA. So this would require some specific development of a platform, but to my knowledge, nobody has done that yet. So I think, would it be of some value? I think it would be.
I just want to add that the TCGA paper, oh, now we have your video.
Yeah.
So I want to add that TCGA paper has in the supplement has a computer, small program algorithm how from the RNA-seq to generate TDS scores. But like Dr. Fagin said, there is no kind of an easy way to do it. You still have to have a bioinformatician who would take the RNA-seq data and then generate the TDS score. But this information is publicly available.
Yeah, and we have done this, but always on RNA-seq on the biopsy samples of the patients, as I illustrated. So it's certainly doable, but it's an excellent question in terms of how do we make this a practical use to clinicians. Right now, there is no tool that is commercially available to do this. I think it's clearly something that could be developed. Certainly in the breast cancer field, there are gene expression profiling approaches that do stratify for risk. So I think this should be something that's feasible. In the second question related to ERK inhibitors, and yes, these ERK inhibitors are sort of there's several that have been developed. They have not been studied in the context of thyroid cancer treatment, to my knowledge. And certainly no trials that I'm aware of that have looked at that in the differentiation context. But finally, and I'll be talking about this afternoon a little bit, there are combination therapies to try and get more profound MAP kinase pathway inhibition, and that certainly is a direction that could be followed.
Thank you. There is also a question that was partially answered, but perhaps I will read it again. What makes a tumor mutate? If mutations occur over time, unpredictably, would it be logical to want to intervene before the tumor mutates? This is one question. And then, I guess, Dr. Fagin partially answers this question, but I would just reiterate that yes, that mutations occur early in tumor development, at least the sort of early mutations such as BRAF, RAS, and then there is a later mutation such as TERT, P53 that usually occur at later in a more subclonal fashion. So kind of, the intrinsic part of the tumor, and it would be nice to find a way to protect mutation from occurring. But really, when we deal with the tumor, it's kind of too late to really to undo it. And then the second question is, are tumors homogeneous or heterogeneous? If heterogeneous, how do we know what we are dealing with, mutated or not, and what mutation. I can start, and perhaps then maybe people from the panel, will pitch in. There are certain tumor types, let's say pancreatic cancer, colon cancer, that are known to be extremely genetically heterogeneous. So when you look at different areas of tumors, we will see very, very different, not very different, but frequently we see a different mutation profiles. At least sort of that's my understanding. Thyroid tumors are much more homogeneous in terms of their heterogeneity. They may morphologically, they may look somewhat differently, but typically these early mutations, BRAF, RAS, fusions, they typically present in most of the cells within the tumor. This is our experience, this experience that was published, but I wonder if Dr. Fagin and others have different experience or different feeling about it.
I agree with what you're saying, Yuri. I mean, the other good example of which there are actually published studies are renal cell cancer, where there's a study in the New England Journal of Medicine where they did multiple sampling of renal cancers showing diversity of mutations. But in the context of thyroid cancer, as you said, the key drivers, and the ones that are primarily targetable with specific small molecules, are actually early events in tumorigenesis and occur in a homogeneous fashion across the tumor. But as you get more advanced disease, and certainly when you start getting mutations of genes such as P53 or ATM mutations and others that for a more unstable genome, then you start seeing subclonal events. And there, if you sample different regions of the tumor, might predict you're going to see some diversity, but always the key initial drivers are going to be there. So no, I agree with what you said.
And I think from a clinical standpoint, we've learned from the papillary microcarcinomas we've been watching, where like 80% don't change, but 10 or 20% change, and they change along a very predictable growth rate. We've now, after 500 patients, finally found one patient that was stable for 4 or 5 years and then started to grow. Now, not rapidly, but it began to grow, and I had multiple ones before that. So out of 505 patients, whatever pace they started on, that's the way they stayed for 5 years. And we finally found the exception that we all knew would eventually happen. Presumably, that patient had another mutation or the microenvironment or something changed. So at least in that early, well-differentiated papillary, whatever pattern they are on certainly feels homogeneous. And the likelihood of picking up other mutations, at least over a 5-year period, in those really carefully selected ones seems pretty low.
Thank you. Next question. Well, first a compliment. Great talks, congratulations. Greeting from Brazil to Professor Tuttle and Professor Fagin. What is the role of molecular markers in the decision-making for active surveillance for microcarcinomas? A question from Dr. Carolina Ferres.
Yeah, they always say nice things and then ask us a question we can't answer, right? And that's the way this usually works. So right now, we're not using molecular markers to predict which ones to do active surveillance on. But I think that's largely because our clinical selection for active surveillance largely rules out aggressive tumors. If you've got extrathyroid extension, if you've got lymph node metastasis, if you've got those things, those tend to be the BRAF tumors, at least the ones that are going to be more aggressive. So I think our clinical selection process, at least in the papillary story, allows us to rule out most of the ones that would have complex mutations. And we're always worried that maybe I watch one. Well, in 6 months, it's a little bit bigger, or a year, it's a little bit bigger. So right now, we're not requiring upfront. As we begin to think about maybe watching some of those RAS tumors, which we're not doing now, right? The papillary microcarcinoma is always papillary cancer. And when those guys recur, it's in the neck and lymph nodes. But as we begin to think about maybe watching RAS tumors, that may be different, right? If we knew it had one of those multiple mutations, RAS plus TERT or something else, because on the RAS tumors, we can't be comfortable that they're either going to grow or get lymph node metastasis. So we're not there yet, but maybe when we think about watching those, the answer about molecular would be different in 3-4 than it is in papillary. Jim?
No, I agree. I mean, sort of in general, I guess one of my, you know, I would certainly love to see that every single patient that I take care of, we could get a genotype on. But, you know, and I realize that certain across the street from us at New York Hospital Cornell, all the patients that have a total thyroidectomy there at least get their BRAF tested. I don't know how comprehensive their panel is, but we don't do it. And one of that has been a constraint for us. Are our patients going to be properly reimbursed for this or not? Because if I knew that that was the case, it does certainly adds value in terms of my decision making about who I treat with radioactive iodine and who I don't, who I suggest completion thyroidectomy along the lines of what you just showed, Yuri, with that, you know, outlier case that you know, had a PIK3CA mutation, you know. So these are factors that will certainly influence our management. And actually, I'd like to see patients who come preoperatively who've had a, you know, indeterminate FNA result and actually have had their tumor sequence, because it allows for much more informed decision making. It's not widely distributed, and we're not really able to use that information clinically. I mean, we extrapolate the information based on the presence of cell variant papillary cancer that we know what that represents, but by and large, we don't know what the genotype is when we treat our patients.
Very good. There is a next question that is actually sort of, you know, continues the same discussion. Can we use immunohistochemistry for BRAF and KRAS to screen these patients in an attempt to risk stratify them? Is IHC reliable in this setting? I think there are several people who can answer this question. And I just before even I want to say that from Maria Cabanillas, who is our faculty in the afternoon, she already sent and saying that she sometimes used BRAF immunohistochemistry as a relatively inexpensive way to look at the tumors. So any panelist who would like to take this question.
Well, I don't want to monopolize the responses, but since we did the study with Ronnie Gossain that was published in JCNM, at least for BRAF, we found this to be extremely useful as an approach to do immunohistochemistry for BRAF V600E. We found that it was, in all the cases, it correlated beautifully with the mutation status and also that was present in all cells, again, supporting that this is a clonal mutation. KRAS is a rare mutation in thyroid cancer. So, I mean, if there were a good antibody for NRAS Q61R, that might be useful. Maybe there is already, but I don't know about how sensitive it is.
Yeah, I was going to ask Yuri too, because we definitely do BRAF, and I see a RAS immunostain, but many times the RAS immunostain doesn't match up with your ThyroSeq. Can you comment on that?
So BRAF is a relatively reliable, not relatively, it is quite reliable and well validated. And remember, it's a mutation specific. It's only V600E specific mutation. So, and yes, it can be used. I mean, we discussed the caveat, but it can be used to have a pretty good estimation of the presence of BRAF V600E mutation. RAS, as according to my knowledge, there is no good RAS-specific antibody. So I do not really believe that there is a significant, unless somebody comes with a mutation-specific, then you need to do multiple, because there are 2-3 types of K61 and HN61 mutations. So I don't see it as something that will be clinically used. But if I may, I just want to stress one more point, that if you really want to prognosticate cancer, unfortunately, neither BRAF alone nor RAS alone is sufficient today to truly prognosticate cancer. Because there is a huge difference between RAS-positive tumors alone and RAS and TERT. That's practically 2 different diseases, or BRAF alone and BRAF plus TERT, or BRAF plus AKT1 or P53. So it would be misleading if you, let's say you have a stain for NRAS and you do NRAS staining and you see it's positive, then what? If it's only NRAS, it's still very low risk follicular type tumor. If it's NRAS and TERT, that's a tumor that has much higher potential to metastasize to distant sites and kill the patient. So I think that I just want to warn that it may be somewhat dangerous to use single markers and accept them as a full prognostication of a given thyroid cancer.
Agree. The other place the BRAF immunostain is likely to be helpful is in the infrequent anaplastics, right? That you need to know very quickly so that you can do dabrafenib and trametinib. So in that setting where people may not have access to rapid molecular, right, that immunostain really drives decision-making there.
Absolutely. And Dr. Cabanillas, she will cover it in the afternoon. And just a preview to answer your question. Yes, the ATA guidelines that are just, I don't know, either published or about to publish indicate that IHC for BRAF can be used as an early fast screening of these tumors.
Yuri, the ATC guidelines are available online, but not formally published yet, but you can get them at the ATA website.
Wonderful. Thank you, Vic, for clarification. So there are several other questions from Dr. Guido Fada in Italy, from Sicily. Dr. Fada, welcome. Which parameters is TDS based on? TDS is based on the, I believe, 16 genes associated with thyroid differentiation, such as thyroglobulin, TSHR, transcription factors, pendrin, and so on and so forth. So these thyroid-specific genes are listed in the paper published by the TCGA. A question from Dr. Natalia Anchipalovsky. A question to Dr. Tuttle. Now I am confused with the management of small, less than 1 cm thyroid nodules. When they grow in 1 year from 0.6 cm to 0.9 cm, still less than 1 cm, do we still observe them or send to the FNA? What if they have aggressive genetic profile, question mark?
Yeah, that's always the challenge of showing an outlier case to make a point, right? So Yuri spent a long time to find that one case that was the outlier case. I've got 500 that haven't done that. So I think the real point of that was, particularly that case, that was a different tumor, right? That's a RAS, a Bethesda 3/4. In the papillary cancers that we do with active surveillance, if something really changes 6 to 9 millimeters in 6 months, yes, we're probably going to do something about that, because that makes you think, well, maybe this is one that has that funny profile and it just needs to come out of there. On the other hand, if you change 6 to 9 months, 6 to 9 millimeters over 5 years or 10 years, we may choose to keep watching that depending on where it is. So we use location, size, rate of change, patient preference, that sort of stuff. So no, by and large, if the ones that we've seen grow, it takes me a year or 2 years to figure out that they're growing. Because remember, the coefficient of variation on the ultrasound is kind of plus or minus 3 millimeters anyway. So for me to really be able to tell which ones of these are growing, it's at least a year. So I think the worry about, you know, accidentally watching something that's really aggressive or really high mutational profile, they probably have already excluded themselves from the program to begin with because they've got other features, extrathyroid extension or something like that, or they grow just inappropriately the first 6 months or a year and you take them out.
I just want to kind of little bit rehabilitate myself, so to speak. You know, if we are talking about small tumors with molecular high risk molecular profile, we actually have many more than few of them. But the point is still what Dr. Tuttle was saying, that still statistically, we are talking about probably 1% of all microcarcinomas. I think it's very important to recognize that this is, that's why I think it's a big advantage to know it ahead of time if we know that this is, and react on them very aggressively if we see this profile even in microcarcinoma. But is it cost effective to look at 100 cases to find one? That's obviously a question that remain open, and the answer may be even no. So I agree totally with this.
Yeah. And I think it's important that we just don't get fixated on a 5 millimeter or size, right? Papillary microcarcinoma, 10% of the time have clinical N1B disease. So it's a papillary microcarcinoma, but they've got big lymph node metastasis. We don't think about that as a papillary microcarcinoma, but they're up front. When we've looked at our papillary microcarcinomas that had distant metastasis, what, maybe 5 or 6 over the last 20 years, every one of them presented as bad disease. Yeah, it was a small primary tumor, but they had 3-centimeter lymph node metastasis, or they presented with a bone metastasis or a brain metastasis. So they had declared themselves early on as being something different than just a little small tumor.
Very good, thank you. So next, the question is from Turkey. First, it's a compliment to Dr. Seza. Thank you for your excellent talk, which we use as a Turkish Society of Nuclear Medicine. As you know, thyroid cancer is very common in Turkey, second in women according to Turkish Health Ministry, but not as common within the leading reason cause of death as expected. Then the question, do you recommend to spare the limited funds in healthcare area to genomic profile of cytology specimens, or still use the classical risk stratification?
I guess I should take this one. I don't think molecular testing is, or routine use of molecular testing in Turkey is ready for prime time. But I think nuclear medicine and pathology worlds should get together and at least working together should make progress in the research area. That can be done because there's a lot of clinical material. And there are lots of ideas that you can accomplish a lot in the research area. But the short answer to the question, it is not ready for routine use in clinical practice.
Well, I'm not entirely sure just what you mean it's not ready. It is very ready and it's very actively used in the United States. It has been approved in Canada, in Quebec by the government to use. So to say that it's not ready, it's very difficult to understand exactly what message you're saying. Scientifically
in the context of
not ready?
No. It's in the context of
right.
the healthcare
exactly
situation in the country.
So what probably you mean to say that the cost, when we factor
the cost effectivity
of the test into the healthcare structure and healthcare system of the country, the cost effectiveness would not justify spending this cost on healthcare. But again, I think that not ready. I hope. I mean,
no. Yeah, you misunderstood. Like, we attempted to send some patients to you. How much do you charge for international patients?
So, well, you know. Actually, we have requests from Turkey, from 2 labs to start sending this. I cannot tell you how much we charge openly because it will conflict with the CMS in the payment in the United States. But I will be happy to provide this information to you offline. So then next we have comments and questions. Perhaps for comments, very nice comments, but I'm afraid that we will not have time. But let's see, maybe we can answer some question, couple questions. Interested in comments regarding repeated high-dose I-131 therapy in patients. Repeated high-dose iodine-131 therapy in patients with bone metastasis and good response. After an initial high dose of iodine-131 with good response, biochemical and imaging. What are the parameters to redose? Rise in thyroglobulin, change in imaging, both, neither, question mark.
Do that one, Vic.
Yeah, I mean, I think there's not an absolute answer to this. You see how the patient is responding, how durable is the response. I think Seza's talked about the indifference, and so it may pick up radioiodine, but it may not respond. The thyroglobulin can definitely, you can use that, but I hate to treat the thyroglobulin in and of itself. It's nice to see that we're seeing some disease response radioactive iodine. The other thing is I always look for local disease, because local disease you can more effectively potentially treat with surgical intervention, or potentially if it's a bone met, you can do external beam and such. So and typically don't go above, 1,000 millicuries of radioiodine. Try not to go above 600. Can you? Yes, but then you get concerned about the secondary cancers and leukemias and stuff like that. But I think I grew up we gave a lot of radioiodine where I trained. And I have backed off because I've seen us get minimal benefit. I'm not convinced we were really helping the patient. And I've done a lot more again with trying to do local treatments and stuff. Of course, now we have systemic therapy, which we didn't used to. And then you have to start to wonder if the thyroglobulin not really responding for a prolonged period of time. I think Doug said, is it 6 months? Is a year? What is a reasonable thing that you really believe it responds? And so I think you have to integrate what's the anatomical response, what's the biochemical response, how's the patient doing, they having any side effects from the tumors and stuff, side effects from the radioiodine, and you have to put that all together. And this is why we have tumor boards, and we sit and we discuss these, and we go back and forth, and we do this in conjunction with our nuke med colleagues, and we say, well, what do we think? What are we really going to achieve? We have our medical oncologists there, radiation oncologists, and we come up to it with an integrated plan. So it's a very difficult question to give an exact answer to, but that's kind of what I would say. I don't know if others have anything else they would add.
Dr. Bernet, there is another question for you. You mentioned 3 injections of recombinant TSH for radioactive iodine. I have usually used only 2. Can you elaborate on the protocols that you use?
So yes, and this is something I know I've talked to like Paul Ladenson up at Hopkins and various places, and this is when we do a combined scan and treatment in the same week. And on Monday and Tuesday, we will give recombinant human TSH injections. We'll see how high the TSH gets. We get an I-123 scan, and then we get results back. And on Thursday, we have those results. We give them another recombinant human TSH injection. We do check the TSH on Friday, but it's usually pretty good, and well over 30 for sure, many times in the hundreds. And then we give our dose on that day 5, and then we scan the next week. It reduces the cost for the patient. It seemed to be very successful. Technically, I think it's off-label use because that wasn't studied, but I know multiple facilities that do that, and I would throw out, I don't know, others. Mike, at Kettering, what do you do in regards to if you're going to scan and treat in the same, or any of the other panelists?
So we routinely scan and treat the same week off of 2 shots. So they get like Thyrogen Monday and Tuesday. On Tuesday, we do a little tracer dose of I-123, and then Wednesday morning do the scan and do the treatment Wednesday afternoon. Now that does require us to select the dose on Tuesday. So we're selecting the dose before we see the scan. And because we work in Manhattan, if we decide to change the dose the next day, we can. We can bring extra radioactive iodine in. We've got a nuclear medicine pharmacy, we can divide the dose. So the ability for us to be able to modify that dose, the likelihood of us changing that dose is 1 or 2%. So when we select the dose before, now to be fair, that's an I-123 scan. The dose may be modified a little bit more if we had I-124 or dosimetry spec CT, and I'm sure Doug Van Nostrand will talk about the type of scan will also influence your results, but we do it off 2 shots and it works well for us, and it's just 1 kit that way.
So it's 12 o'clock and we have 2 questions remaining. One is short, one is longer. Dr. Gulec, what is your preference and the panelists? Are we going to stay extra 10 minutes and go through them, or
we could, let's pick the short one first.
Okay.
Is there any link between the multicentric tumors and their genetic profile? And thanks for the excellent conference. So what do you say, Yuri?
So I said that there are 2 types of multicentric thyroid tumors. There is a dissemination of tumor in the gland, and there are separate independent primary nodules. Both conditions are very common. So what we find, and we published a few years ago on this. So the BRAF-like tumors, BRAF V600T, have tendency for more lymphatic spread and more common multicentricity as a spread of the tumor. RAS-like virtually never gives this. Sometimes we see two nodules in one lobe, and one will be NRAS positive and another will be HRAS positive. So this tumor really arises as an independent primaries. And I want to say just in general that the thyroid, obviously doing a lot of analysis of multiple nodules, rather frequently have this separate independent nodules that can be present in one and the second lobe. I don't know if anybody else have any additional comments on it.
So it's 1204.
So there is one patient, I mean, kind of a clinical case, there is a question. I believe that, as I see, this is probably the last one that we have. I don't know if we have time, we can discuss this question.
Sure, go ahead.
How would you manage the following patient? 64-year-old female, total thyroidectomy plus central lymph node dissection. Pathology, 2CM, papillary thyroid carcinoma, no high-risk features, aggressive histology. 1 out of 6 lymph nodes has metastasis, 0.7 millimeter in size of metastasis. Molecular profile not done. Post-operatively, after 4 weeks, serum TSH under 30, TG 18, antibody negative, neck ultrasound, 1 cystic lymph node in lateral neck, no other abnormalities, missed on pre-surgery mapping. Question mark, resurgery for lateral node, cytology prior to resurgery, TG wash, question mark. RAI therapy without surgery, question mark. If patient is reluctant, what dose? Would you perform chest CT or diagnostic whole body imaging in this patient?
Listen, Vic, I'll be glad to tackle a couple of that. One, it would be helpful to know the size of the node, but it sounds like an abnormal node. I mean, it's easy to do ultrasound guided FNA, and if I do of a lymph node, I always do it with thyroglobulin washing. There's no reason not to do that, and it's helpful if it's the node's negative, but it's positive. And I don't think, and I'm curious maybe what Seza has to say on this, but if it's over 1 centimeter, I'm not going to think the radioiodine is going to knock it out. So I would probably want to make sure I had a very good lymph node mapping and send the surgeon in and not just pluck that out, but do a good look around. And then if that's positive, it's a 64-year-old, it's a lateral lymph node. I may lean towards doing some radioiodine, but I'm probably not going to try to treat a lymph node with radioiodine most of the time unless it's maybe tiny and stuff like that. And the chest CT, well, I don't know. I mean, you can do that. The problem is a 64-year-old has a high chance of having some nodules anyway, and then you're left with, you don't know what to do with that. It doesn't seem like the most concerning thing. Again, maybe molecular profiling would be helpful here, to tell us what to do. And Seza, would you treat a lymph node greater than a centimeter or a lymph node period like this with radioiodine, or would you?
No, I would do the FNA. And because it's cystic, you may not hit the meat. So definitely be prepared to do thyroglobulin and the aspirin. If it's positive, I would do a lateral neck dissection. As to the CT, yes, I would do the CT. Most commonly missed sites is level 7. Just to make sure that you're not missing anything in level 7. This is an unexpected finding. It wasn't discovered preoperatively. So you don't want to miss another missed lymph node.
Yeah.
So that's what I would do.
One comment on the TG washing, it's extremely easy. I do these very frequently, and I do 3 needle sticks, do a 27 gauge needle. You do not need to use a big needle. And we have a very high positivity rate in the ones that are suspicious. And if we get negative on that, then we send it for the thyroglobulin. That's lateral neck. Central neck you get into, could there be residual tissue, and then the thyroglobulin signal is not going to necessarily tell you anything. And if it was diagnostic for cancer cells, but if they say, oh, they're indeterminate cells, you can't use it as well. But it's very easy to do. And be careful when you order this. I'm still surprised on this as well, how many facilities are doing ultrasound guided FNA, but they're not doing thyroglobulin washings on the lymph nodes. I would say it's essential.
Very good, thank you. We have two more sort of partially comments, partially questions, but I think that in the sake of time, we should proceed with a break, and then we'll keep them for the second Q&A session in the evening. If we have time, we will also go through these comments and questions. Thank you very much, and I believe we will resume in 1 hour at 1 o'clock Eastern time for the afternoon session.
Excellent.